Hello, everyone. I'm Helen Collis, Health Editor at Politico, and I'm delighted to be joined on the stage this morning by Emer Cooke, Executive Director of the European Medicines Agency. Thank you for joining us, Emer. Emer, you've been at the helm of the Europe's Drugs Agency since November 2020, but to me at least it feels like a lot longer. That's because you stepped in to lead the agency at the height of the pandemic when the regulator was thrown into the spotlight. The EMA responded by hosting weekly press conferences, sometimes more, elevating not only the EMA, but also yourself onto the world stage. The pandemic has had a lasting effect on the drugs regulator, and one of those has been its new role in helping to tackle drug shortages, which we've been talking a lot about this morning. I spoke with Frank van den Broek, the Health Minister and Deputy Prime Minister in Belgium earlier, who told me that the solidarity mechanism, for example, is working very well. Can you share with us what EMA's role is in helping to tackle drug shortages?
Yeah, thank you very much, Helen, and indeed it's a pleasure to be here. And I was very struck by what Frank said in the introduction today, because obviously managing shortages is one of our priorities at the moment. We expect it to have a even higher profile in the new Commission with the Critical Medicines Act. But I do think it's a big success story from the point of view of the European Medicines Agency. And indeed the whole European Medicines Regulatory Network, because at the time of the pandemic, exactly 4 years ago, which is when I took over. Now, of course, the pandemic started before that, but we had this major problem with shortages, and you could see what was happening. China was shutting down, then India was shutting down, then there was a lack of supply of intensive care medicines. There were no respirators. You know, there was a real challenge, and we had no legal mandate to do anything on shortages. But we did get together a steering group of all the medicines regulators across Europe. We had weekly meetings with Commission colleagues. We had meetings with industry colleagues telling us what was happening with freight, travel, what we could expect, try to move product from one area to another. And in fact, the idea of this solidarity mechanism was actually born during that time, because some countries had not enough, and some countries had more. It's as simple as that. And one of the things that we realized then was that actually we don't have enough visibility about where everything is. So we need to build that mechanism. So it started by literally saying, one country saying, I have a need for intensive care medicines, and another country saying, well, I've got a few here I can share with you. And it was built on personal relationships. Now, in the context of, or spurred on, I would say, by the Commission's communication on shortages in October last year, we at EMA have put in place this voluntary solidarity mechanism, which, as Frank said, was a last resort mechanism, but actually it's been working really well. A medicines authority will say, I have a real problem on a thrombolytic, can you help? And then the other authorities look at what they can, what they have in stock in countries and share. And we've had probably about 10 solidarity exchanges since basically this time last year. So we're trying to make it more visible. We had initiated as a last resort mechanism, but actually it's also valuable in a second last resort mechanism.
Very interesting. Thanks so much for sharing that with us. I want to look at some of the other areas that the EMA is working on to be better prepared for the next health threat. Among the criticisms that the EMA came under during the pandemic was that it was always playing catch up to the UK and the US in approving its vaccines and treatments. But at the time, the EMA and yourself told us that they were working around the clock to ensure that every scientific evaluation that was completed didn't cut any corners. And you said at the time it was vital that European citizens citizens have full confidence in the vaccines that they receive. We know that the US Food and Drug Administration, for example, had emergency use authorizations, which did seem to get things through a bit quicker. And we know that the European pharmaceutical legislation that we're still discussing in the European Council at the moment has a similar proposal. I'd like to get your thoughts on that proposal and whether or not you think it would expedite a new vaccine in a new pandemic, for example, in the future.
Yeah, so these are things that we reflect on all the time. You know, had we got the right tools? Did we do the right thing? We were working around the clock. We were trying to think differently. We were trying to make sure that we had the right evidence to support the decisions that we were making for European citizens. Personally, I'm very proud of what we did. I still find it hard that a 2-week gap is seen as a major difference between the outcomes, the authorizations in Europe and in the US. I believe that the European Union's vaccine strategy was an absolute game changer. The first time that all 27 member states had access to innovative vaccines within days of the actual authorization and within 9 months of the of development. That is, it's a fantastic achievement. Now, we didn't have a provision for emergency use authorization. We used the conditional marketing authorization, which meant we had to fulfill all the legal requirements. So that's why it was actually tougher, because we hadn't got any leeway. We hadn't got potential for deviation. But it was a great reassurance to us that we were ticking all the boxes, we're making sure that we had all the evidence needed to be confident that the products that we were authorizing were safe, quality, of high quality and effective, and that we had mechanisms in place to follow the post-marketing, any adverse events that might arise. Now, in the new package of from the pharmaceutical legislation, there is a provision for a temporary use authorization at European level. And if this is maintained in the final package, we will look and see how it fits in. It's always good to have more tools. As I said, we weren't able to deviate from any requirements during the pandemic. I think particularly for therapeutics, we struggled with with less data. We had a lot of data on the vaccines, but with some of the therapeutics, we struggled with the amount of data that could be available, and yet there was a big need here. So maybe that's an area where an emergency use authorization could be very useful.
Do you think, are there any greater risks involved in taking this kind of approach? Greater uncertainty around the safety and efficacy of any new vaccine, for example?
Well, as I said, I think it's probably more likely that we'll use it in the therapeutic area. But of course, we are dealing with uncertain situations. In emergency, in crisis, we're dealing with uncertain situations. Science is evolving, data is evolving, and we have to be on top of this. But we have to take calculated risks, depending on what the real risks to the patients are. So if 80% of the population is dying, you're going to take a different risk if 10% of the population is dying.
And we heard from somebody in the audience this morning about real concerns about vaccine hesitancy that have persisted since the pandemic. If we do go down this route in EU legislation to have temporary use authorization, what conditions do you think should be attached to it? Well, I think we will always maintain our responsibility that the products that we authorize have a positive benefit risk for the populations that they're going to be used for. And that is a message that we will continue to give to the European citizens.
but I think it's very important that we involve stakeholders in our decisions as well, because one of the things, and you mentioned it, that we actually did a huge amount of outreach during COVID. We involved patients, we involved citizens, we asked them what they wanted, what they needed, what would help for them to have confidence. So I think these are measures that we will continue to have to invest in. I think we're all very conscious that there is a changing dynamic on trust and confidence in public institutions. It's hard for me as, a seasoned regulator to really understand how I can change the needle here. I firmly believe that our network is doing the right thing for the European citizens. I think we are transparent. We are transparent. I don't think we are transparent. We are transparent. We listen to stakeholders. We listen to patients. We listen to citizens. We are fact-based. We try to make everything as comprehensible as possible. I would say we can do some more in terms of language, maybe moving away from scientific language to simpler language. I think this can help. But I think a lot of it is about understanding what the concerns are, making sure that any concerns that are articulated, that we can provide fact-based responses to that, and that we hold ourselves up as being transparent and accountable.
Mm-hmm. And we heard similar comments yesterday from the head of the ECDC, Pamela Rendi-Wagner, around the language that's used to communicate these things. Staying on the topic of vaccines, I want to get your thoughts on what is happening over in the United States at the moment. Donald Trump has chosen Robert F. Kennedy Jr. to be the next State Secretary of Health and Human Services. He's been very outspoken on vaccines, especially childhood vaccines. And your counterpart at the US Food and Drug Administration, Robert Califf, said last week, he raised concerns about who might replace him at the FDA. And he said that he hopes the next FDA chief, in quotes, really appreciates the critical role of high-quality evidence in everything that we do. Are you also concerned about the direction that the US might take towards vaccines and evidence-based medicine generally?
Well, I have a strong belief that science and what is right will prevail. And we have a long-standing relationship with the US FDA, very, very valuable partners, and both at a bilateral but also at a multilateral level in helping us provide good solutions that meet global health concerns. Our relationship with the FDA goes back many, many years, but we've had formal collaboration over more than 20 years. We know many of the individuals in the organization personally. We can pick up the phone to them. We have a challenge, we have a challenge, we can help, they help. I believe, and this has been across administrations, that's really the message I wanted to say. It hasn't been that, this administration we did this, and this administration we did that. The relationship that we've built up has not only developed but flourished across the administrations, and that's because I believe that the motivation of FDA to serve public health is aligned with our motivation to serve public health, and we want to do this right.
So you don't think a change of leadership at the FDA, for example, would have any impact on your relationship with the agency?
Of course, I don't know what impact. I can't predict the future, but I think the main worry I would have is about the individuals working in the organization. If there was to be major changes there, it is something that we will have to build up new relationships, we'll have to build up new understandings. We'll also, I have regular meetings with the current US FDA Commissioner. I would expect to have regular meetings with the US FDA Commissioner to come. Maybe if I can just mention one of the tools that has helped in our cooperation with the FDA. We have an FDA staff member who sits in our offices in Amsterdam. It's called our liaison program, and we send somebody to FDA to sit in their offices there as well. And this helps us. It's a very complex network of interactions between the FDA. It's not just one thing. You know, we work on oncology, we work on orphan drugs, we work on manufacturing, we work on the whole gamut of medicines regulation, and our liaison placements help us to manage this very effectively.
The US actually has quite a high uptake of childhood immunisations at the moment. It's mandated by most of the school districts over there. But scientists in Europe have already raised concerns over what impact a drop in vaccination rates might have beyond its shores. Is this something that also concerns you?
Yes, of course. I mean, vaccines are probably the biggest public health tool we've ever had. We have seen changes in disease epidemiology, in life expectancy through vaccines. I mean, for me, I'm sorry, I'm a lot older than the people who are now vaccinating their children, but I didn't think twice about vaccinating my children because I knew I wanted to have the best opportunity in life, and I thought this is something that helps them have the best opportunity. And of course, I think about it now, was that the right thing to do? And of course, I'm convinced it was. I remember also the HPV vaccine, for example. And that was at a different stage, you know, when my daughter was going to school, and there was less evidence at the time. But then I looked at the evidence and I said, that's worth it. So I do hope people will make decisions based on the facts and the science and the experience. And I do hope that we can help give those messages. And if we're not giving the messages in the right way, please help us to do that.
Thank you. I want to change tack now, and just in the last few minutes, find out what the EMA is doing to handle this new evidence that's being generated by AI, or how AI is being used in the discovery, development, testing, and results analysis of medicines. Can you tell us how the EMA is handling this new approach in AI technology?
Yes, so first of all, I'm again very proud of what we're doing in the AI area. I think we have come out with a number of guidance documents, roadmaps on AI in advance of a number of different regulators across the world. We published a reflection paper on how AI is used in medicines development, authorization, and post-marketing follow-up. We had, I think it was in July that we had the draft, and we published the final document on at the end of September. We've also published a guidance on large language models, and it's all designed to help us navigate how to use AI in the medicines development and evaluation process, but also from our own perspective in trying to get our, to have us do more efficient work, to improve our processes, and to see, to really use the advantages of AI to trawl through huge amounts of data. At the same time, making sure that we do address potential risks, biases, which there will always be. So I think it's about putting frameworks in place. It's also about making sure that we are educating our own staff, that the people who are providing data to us or using AI are really know what they're doing, and that we know that they know what they're doing. And I think this is a change in paradigm. It is a learning experience for everybody, but I think we all have a collective responsibility to do the right thing and make the most of it.
And thinking about the next pandemic situation or the next health crisis where we need a quick decision on a new vaccine or therapeutic option, does it take longer to assess a product that has been developed using a lot of AI technology? Would it slow down that process?
That's a good question. It shouldn't, but it'll depend on how transparent and how the data has been presented. So if we are confident in the way that the AI has been used, then it will help. If the methodology doesn't instill confidence, then it could cause challenges.
Thank you so much. We've reached the end of our slotted time, so thank you so much, Emer Cooke, for joining us this morning. If I can ask you all to remain seated, please. We now have a panel discussion on advancing prevention strategies to combat infectious diseases, moderated once again by Rory O'Neill. Thank you. Thank you very much. Thank you.